And then let me make you the host. Awesome. We can see your screen, sir. Cardiovascular disease review.
Got it.
All right. I'd like to introduce you guys to Dr. Matthew Eschelbach. He actually is our assistant medical director. He's also the medical director, as you can see there, of trauma and EMS in Redmond, Oregon. He, to my understanding, does a great deal of lecturing on the EMS circuit and otherwise, and we're very fortunate to have him come and teach Roundtable for us about once or twice a month. And so give your entire attention and note your questions down. I'll open up a chat room on the side and try to keep an eye on in case we catch something that you throw up there. Or since it's such a small group, if you guys would like to unmute your microphone when Dr. Eschelbach takes a breath and asks a question, he'll be happy to answer them. Just remember to remute your microphones so that your noise around you doesn't interrupt the lecture. But you do need to participate to get credit. And once we get to the end, we'll check in with you again, and then I will be posting your credit in EMS testing after this is done tonight. So I would like to introduce you to Dr. Matthew Eschelbach, and I believe, sir, we are ready to go.
All right. Good evening, everybody. Tonight we're going to be talking about cardiovascular disease review. This is kind of a very broad topic. It's got a lot of different aspects to it. We're going to talk about several different aspects of cardiovascular disease, including the concept of acute coronary syndrome, which I'll introduce you to. So we'll just move forward. And this does have, it's rather heavy in about 4 or 5 different videos, so make sure you have your sound turned on. Just quick facts. The heart beats on average about 70 times a minute, 4,200 times an hour, 100,000 beats per day, 365 million beats a year. That's about 30 billion beats in the average lifetime. It's an amazing organ, and the adult heart will pump about you'll hear anywhere between 6,000 and 7,500 liters of blood daily. And it takes about 20 seconds to pump blood to every cell in your body. Unfortunately, cardiovascular disease is also the #1 cause of death in the United States. And sometimes the very first indication that there's a heart disease or a heart problem is when people go into an acute coronary event. Cardiac arrest is the most severe manifestation of acute coronary syndrome, and it's that rapid intervention that EMS can make a difference between life and death. In general, cardiovascular disease claims about 1 million lives per year. Cardiovascular disease is the leading cause of death since 1900, and sudden cardiac death accounts for about 40% of these deaths, and it's the major response for 911 calls for all our chest pain. Cardiovascular disease can be controlled, and these are the controllable factors, the things that a patient can change. #1 is smoking. #2, high blood pressure. #3, elevated cholesterol levels. And I'll go over why this is so important when we talk about lipids inside diseased vessels. Elevated blood glucose levels or diabetes. Diet, lack of exercise by changing it over and increasing exercise, and stress. We could all do with less stress. These are the things we can't change. Every minute of the day we get older. For you guys, it's not anything to worry about. You know, you're young, you're vibrant, but as you get older, like myself, age becomes something that's more of it is behind you than ahead of you. You can pick your friends, but you can't pick your family. So family history, if grandma and grandpa, mom and dad had heart disease, that's something you cannot control. Race, a black race has a higher percentage of hypertension and a higher percentage of cardiovascular disease, and by sex, males greater than females. But we will learn that females have atypical symptoms, so we have to be very, very aware of those. Here's basic anatomy. Without going back into cardiology 101 or 101 anatomy, this is a broad view of the heart. There is a left side and a right side, which I'll go over on several occasions in the next few minutes. The left atrium receives blood directly from the lungs, pumps it out to the left ventricle, and then out through the aorta, where that oxygenated or red blood will be sent to the body, then return to the right heart through the vena cava, inferior and superior, and then out to the right ventricle, where it's pumped to the lungs to get reoxygenated. This little, you can watch this little clip here to see exactly how the heart beats. It is a circadian rhythm there. It has two rhythms, the top and the bottom, as the top of the heart will pump to the bottom of the heart, and we can watch. So you can see that the blue blood goes to the lungs, the red blood comes in from the lungs and goes out to the body. It does go through one-way valves. I'll talk about that a little bit when we talk about heart failure and going from there. Circulation, there's a high pressure and a low pressure side. Low pressure is, believe it or not, on the red side, from the lungs to the left atrium is low pressure. However, once we go through the left ventricle and back out, that's the high pressure. That's our systolic, that's our 120 over the 80, which is the low pressure side. There is high pressure between the pulmonary, the aorta and the pulmonary arteries, and that is a high pressure side that will bring it into the lungs. We'll talk a little bit about that when we talk about heart failure. Getting down to the very basics of blood, the red blood cells carry the oxygen to the tissue. They also remove CO2 and waste. The white blood cells fight infection, and the platelets we'll talk about down here, and they're very, very important to us when we talk about the platelets that help blood clot. Now, helping the blood clot are our friends when we're talking about nicking yourself while shaving, or your friends if there's trauma, helping the blood clot. But those platelets clotting are our enemies when we're talking about acute coronary syndrome. There's also the electrical system of the heart. We talked about that in our last lecture when we talked about EKGs. We have an impulse that begins at the sinoatrial node. That's in the ventricle. The sinoatrial node then goes through internodal tracts down to the AV node. And the AV node then will divide into the left and right branches of bundle branches and send that impulse into the conduction pathways of the ventricle.
The heart is a pressure gradient that drives blood flow to the vascular system. Although the heart is a simple structure, it's divided by a central structure, separate parts. The atrium, the ventricle, and alternately back and the then relax and fill and then vascular. The timing of the electrical and mechanical events is decisive, global, ensure efficient cardiac. The timing of atrial and ventricular contract relies on primary cell type, cardiac myocytes, which do the mechanical function, and autorhythmic cells, which initiate and conduct electrical impulses that drive contract balance. Autorhythmic cells cyclically polarize on their own, then fire an action potential time-related threshold, process known as activity. This activity originating from primary pacemaker cells, sinoatrial or SA node, the upper right atrial wall. Pacemaker potential quickly moves to the interatrial pathway, the left atrium, and spread throughout the atrial myocardium via gap junction. As a result, both atria depolarize and contract. The impulses generated by the SA node also rapidly spread through the total pathway to the atrioventricular or AV node at the base of the right atrium. The AV node is the only point of electrical contact with the atria ventricle. Here, the impulse is weakly slow, allowing the atria to contract and see their contact ventricle before ventricular depolarization and contraction. The impulse travels quickly to the bundle of within the interventricular septum. The bundle branches into smaller constricted fibers that radiate throughout the ventricular myocardium. Action potentials travel quickly through the constricted fibers, then spread to the surrounding ventricular myocytes via gap junction. Depolarization triggers contraction. Repolarization triggers relaxation. The swift spread of the impulse through the specialized conduction system ensures that the ventricles become excited and contracted. The spread of cardiac electrical activity may be recorded with an electrode placed on the body surface. The recording, called the electrocardiogram, or has several main components. The P wave corresponds to atrial depolarization. The QRS complex interferes with ventricular depolarization. The T wave represents ventricular depolarization. The P wave initiates atrial contraction, which completes ventricular filling. The QRS complex initiates ventricular contraction, pumps blood out of the heart. During this time, the atria repolarize and relax. The T wave initiates ventricular relaxation, during which the ventricles fill once again. One cardiac cycle.
So you can see that the heart has both electrical properties and mechanical properties that bring it through each cardiac cycle. The heart is also the only organ that's the only organ that is responsible for its own blood supply. And the coronary arteries are the blood supply to the heart. So not only does it pump itself, but as it leaves the aorta, the coronary arteries come off the aorta and supply the heart with the oxygen it needs for the cells. Remember, we estimated that the heart beats in the billions over a lifetime, so it's going to require a large amount of oxygen over its lifetime. Cardiovascular disease is established when people have a high risk of subsequent cardiovascular events, such as myocardial infarction, stroke, and death from cardiovascular disease. We'll break each of these down in a few minutes. There are therapeutic lifestyle changes in the form of increased physical activity, dietary modification, weight loss, smoking cessation, and these are all proven benefits and can improve the outcome as quickly as 6 months. So if you're a smoker, quit now, and for the next 6 months, your heart can try and reestablish itself. There is a point of no return when very often people stop smoking after their first cardiac event. And I say their first cardiac event because as a provider, I often see people who admit to smoking who've already had a heart attack or a bypass graft, and it just amazes me. Drug therapies, which we'll go over briefly, include things that we do to treat heart failure, for example, beta blockers to slow the heart down. ACE inhibitors are medications that are used for blood pressure, and angiotensin blocking receptor blockers are related to ACE inhibitors. And these therapies all work by ameliorating the risk that we talked about for the modifiable risk factors such as blood pressure and decreasing the stress on the heart. Things like diabetes treatment and smoking cessation are also very important. Let's talk a little bit about cardiac output. Cardiac output will be very, very important when we talk about heart failure. It's simply a formula. It's a stroke volume, meaning how much does the heart pump times the heart rate. So each time a heart pumps, it pumps a small amount with each heartbeat, and then if you increase the heart rate, then the cardiac output goes up. So either parameter can increase or decrease the cardiac output. It varies with activity and other factors. Just think about it. What happens when you start to walk upstairs? You walk upstairs, your heart rate goes up, your demand for oxygen goes up. By increasing your heart rate, your body will respond by not only increasing the stroke volume in the heart, but also by increasing the heart rate. Keep in mind also that there's something that we talk about with, when we'll talk about heart failure, we'll talk about something called ejection fraction. Now the heart is a pump and it's fairly efficient. About, in a healthy heart, 50 to 65% of what comes into the heart will go out of the heart, and that's called the stroke volume. In disease states such as heart failure, that number goes down to less than 40%. So people might have a stroke or cardiac output and ejection fraction of only 25 to 30%. And if the heart is only 20 to 30% efficient, it's going to take a whole lot more work, and people wind up getting chest pain, shortness of breath, etc. Blood pressure is simply a formula, just like cardiac output is. It should be measured in every patient over 3 years old. It's the amount of pressure that's exerted on the walls of the artery. We know it is millimeters of mercury, so we say a systolic pressure of 120, and then a diastolic pressure of 85, for example. Cardiac output times the resistance of the vessels is what blood pressure is measured as. It's also heart rate times systemic vascular resistance. And we talked about reducing blood pressure as a treatment. And remember that when you have your equation, we talked about this in algebra, if blood pressure is equal to heart rate times systemic vascular resistance, or if blood pressure is your cardiac output times the resistance of the vessels or systemic vascular resistance. If we decrease something on one side of the equation, blood pressure, then something has to go down on the other side of the equation. So to effectively treat blood pressure, we have to either decrease cardiac output, resistance of the vessels, or heart rate. And each medicine that people take for blood pressure affects blood pressure in such a way. For example, beta blockers. Beta blockers work by decreasing the resting heart rate. By decreasing the heart rate, we decrease blood pressure. Or very often people take diuretics. How do they work? Diuretics work on blood volume. If you use a water pill like Lasix or hydrochlorothiazide, you decrease the amount of water in the blood, therefore decrease the volume. When you decrease the volume, you decrease the cardiac output and you lower blood pressure. Two other very common things, for example, are ACE inhibitors or calcium channel blockers. Calcium channel blockers and ACE inhibitors both dilate vessels. So by dilating a vessel, going from a garden hose to a fire hose, you decrease the systemic vascular resistance, therefore you decrease blood pressure. It's all pretty simple physics and math. What is shock? Shock is hypoperfusion. Shock has 4 different causes: cardiogenic shock, anaphylactic shock, septic shock, or lastly, it could be trauma or volume loss. So it would be traumatic shock. Signs and symptoms such as pale skin, a weak and rapid pulse, rapid shallow breathing, restlessness, anxiety, mental dullness, nausea and vomiting are all signs of shock. What is high blood pressure, or otherwise known as hypertension? And these are the following definitions. Normal blood pressure is the systolic blood pressure of 120 over 80. Prehypertension is 120 to 139. There is talk now of decreasing this 139 to 135, and a diastolic of 80 to 89. High blood pressure is a sustained systolic blood pressure of greater than 140 millimeters of mercury over a diastolic of greater than 90. So treatment for hypertension, which we talked about as a treatable factor for heart disease, should begin when somebody gets into this range of 135 to 140. By lowering the blood pressure, antihypertensives or blood pressure medications, just by bringing it down 4 to 5 millimeters of mercury will reduce the rate of stroke by about 40% and coronary heart disease by 16%. So not surprisingly, the presence of other risk factors in addition to hypertension will cause these significant cardiovascular diseases. And we talked about these already. Talked about lifestyle changes, exercise, smoking, etc. So therapeutic lifestyle changes, those changes that a patient can make, will be to treat their lipids, their cholesterol. You'll see a lot of patients who are on lipid-lowering agents, high blood pressure medications, stopping the smoking, losing weight, increasing physical activity, treating diabetes. All of these will work together to reduce and treat and prevent heart disease. So we talk about a good diet. We're talking at least 30 minutes of exercise a day, at least 3 to 4 times a week, will also make the heart stronger and healthier. All right, this is a very, very fancy slide. I throw it in there because it's not so much a paramedic slide as it is a physician slide, by a physician looking at his patient, trying to figure out what their hemodynamic profile is, what they want to do as a diagnostic implication, and what is the best therapy to start. Very often, patients get started on something simple like a diuretic, or somebody might have rapid heartbeat and we want to use a beta blocker. If you've had a cardiac event, you will most definitely go home from the hospital on a beta blocker. A beta blocker will decrease the beta cells, decrease the rate of heart rate so that the heart doesn't work as hard. We'll talk about this in a few minutes. General management of heart disease then, beta blockers will also treat angina. We'll talk about angina in a few minutes. ACE inhibitors or angiotensin II receptor blockers, which are cousins to each other. Mineral corticoid medications. All of these agents will improve survival. Classic symptoms of chest pain. These are the ones that are classic and standard. A feeling of pressure, fullness, heaviness. Sometimes I saw a patient yesterday in the ER and they said that it felt as if there was an elephant sitting on their chest. That's a classic symptom. Squeezing pain in the center of the chest with radiation. Radiation can be to the neck, arm, jaw, back. Diaphoresis or breaking out in a sweat, nausea, shortness of breath, and weakness. The most common of these is diaphoresis, or breaking out in a sweat, more so than chest pain. Nausea, shortness of breath, and then here's something that you've got to look at that's confounding. God has a sense of humor, and sometimes people can be having a cardiac event and there's absolutely no sign or symptom at all. Figure that out. Atypical presentations are very, very common in the elderly, diabetics, and females. That's why so many of us miss acute coronary events in females, because they'll just complain of feeling tired, or a sudden onset of unusual shortness of breath. Usually we think of maybe something like asthma or pneumonia if there's a sudden onset of that. Nausea, dizziness, weak and dizzy is probably the worst group of symptoms to take care of because it's so broad. We'll see a lot of 80-year-olds who are weak and dizzy, and we got to rule out everything when we talk about that. It could be a stroke, it could be a cardiac event. Belching, burping, and indigestion on Taco Tuesday, atypical presentation. Palpitations or a new dysrhythmia is possible. And pain only in the jaw, not in the chest, only in the neck, only in the back, only in the arm. I once saw somebody who came into the ER that was an acute coronary syndrome that didn't match, and they were in for a toothache. It's a good thing I didn't send them home with antibiotics and pain medication, but something about them told me that this was not a typical scenario. So I didn't treat their toothache, I did an EKG and found a STEMI. So, rule number one is all chest pain is considered to be an acute myocardial infarction until proven otherwise. Angina, or its formal name, angina pectoris, is chest pain caused when the heart tissues don't get enough oxygen for a brief period of time. This typically causes crushing, squeezing type of pain. It's usually brought on with the 3 E's: exercise, eating, or emotion. So if you think back of the guy who is shoveling snow at 7 in the morning and has an MI, that's a typical example of exercise. Sometimes people eating a heavy meal and complaining of chest pain and indigestion. The leading cause of death in 1900 was indigestion. Do you think it was actually indigestion or reflux, or do you think it was cardiac disease? Think about it. And emotion. I like to think of a guy who you guys may not be familiar with because they're very, very old, but there used to be a comedian by the name of Red Fox, and he played Sanford and Son, and he was always emotional and holding his heart and saying the big one was coming, and that's a perfect example of angina. Now, the thing that's nice about angina is it usually resolves with rest, or somebody might take a little bit of nitroglycerin and it goes away. If they rest or take their nitroglycerin and their pain goes away, that's what we call stable angina. Otherwise, if it doesn't go away, it's unstable angina. And it may be difficult to distinguish angina from an MI. What is angina? Way down here at the basic level, this is plaque in the coronary artery. We'll talk about plaque ad nauseum in a few minutes. But when this plaque here, whether through exercise or motion or whatever it is, not enough oxygen gets through here and you're in the coronary artery, this plaque can be your enemy and you get angina. You start to show signs and symptoms of a heart attack. But if you sit down, you rest and take a nitroglycerin, which will expand this artery, more blood gets through and the angina goes away. All right, here's the concept of acute coronary syndrome. Acute coronary syndrome is used to describe a range of conditions from unstable angina all the way to acute myocardial infarction. Signs and symptoms are usually caused by acute MI. We'll talk a little bit about acute coronary syndrome in a minute. What are the signs and symptoms? They're the classic signs and symptoms of MI. Shortness of breath, inadequate perfusion, chest pain, pressure, discomfort, with or without radiation to the neck, back, jaw, arm, or wrists, nausea, weakness, and syncope, passing out, or dysrhythmias. These are all part of the wide spectrum of acute coronary syndrome. The spectrum of clinical conditions are unstable angina that we just talked about, meaning chest pain that does not go away with rest or nitroglycerin, to non-Q wave MI or Q wave MI. Those are what we call non-STEMIs, meaning somebody is having damage to their heart and we don't see it evident on the EKG. It's up to us to figure that out by either signs and symptoms or blood work in the emergency department. And it's usually characterized by a common pathophysiology of a disruptive plaque. Let's go back to this word here, sorry. Atherosclerotic plaque. This is the hardening of the artery or the cholesterol in the wall of the artery that is our enemy in heart disease. We'll show you that plaque in a few minutes.
Acute coronary syndrome, or ACS, is the leading cause of death globally. The spectrum of ACS ranges from unstable angina to non-ST segment elevation myocardial infarction and ST segment elevation myocardial infarction. Ultimately, ACS is the result of an obstruction of the coronary artery induced by an atherosclerotic plaque. ACS events are triggered by the plaque rupturing. This exposes subendothelial matrix proteins and other molecules. Platelets are recruited to the site, adhere to the injury, and, together with red blood cells and fibrins, begin to form an arterial platelet-rich clot. This narrows and eventually obstructs the coronary artery. The extent and the location of the blockage and the resulting myocardial damage determine the extent and the severity of the myocardial infarction. Life-threatening arterial clots are formed through two pathways: activation of platelets and generation of thrombin by coagulation factors. Targeting both pathways has been shown to be a viable therapeutic approach.
Okay, so when we talk about treatment for acute coronary syndrome, we have two arms. The arm on the left is the STEMI. We talked about that last time when we talked about EKGs. STEMI stands for ST elevation myocardial infarction. All right. When we begin treatment, we give antiplatelet therapy. Antiplatelet therapy begins with aspirin. Anti-ischemic or anticoagulant therapy is something that's done in the ER. We might load a patient with heparin. And then we have two pathways. If we have the ability to get that patient onto a cardiac cath table within 60 to 90 minutes, that's the PCI here, that's great. If we don't have that much time, say we're way out in a rural area and it's 2 hours to get a patient to a cardiologist, we should begin thrombolytics. These are the clot-busting agents, and we should begin those in the emergency department. PCI, or a catheterization, is done by a cardiologist, and based on the results of the PCI, they'll either go in and put a stent in and open up a vessel, or if the extent of the damage is too great or too wide, they're going to call a cardiac surgeon, and the cardiac surgeon is going to do a CABG or a coronary artery bypass graft. Once the procedure is done, now both of these can be done together. Once the procedure is done, then we get to the long-term medical management. What about non-STEMIs? Unstable angina, non-STEMI. This is the person who's having chest pain, and despite rest and nitroglycerin, their pain doesn't go away. The cardiologist says, I don't like the way this is going. I think they might be at risk for having a heart attack. They're going to take them to the cath lab. Same treatment, antiplatelet therapy, anti-ischemic therapy, and anticoagulation therapy. The result here is the same as well. Take them to the cath lab. If they can fix it, they will. If not, they call the cardiovascular surgeon, and the cardiovascular surgeon will do a bypass graft. So here's that plaque we talked about. In a normal vessel, over here on the left, there's healthy walls and no cholesterol. As time goes by, we build up the cholesterol inside, and this is what we call a plaque. When that plaque is ruptured, meaning that this cholesterol is exposed to the blood vessels and the blood, that's when we start to get something called thrombosis. And thrombosis will lead to an MI. I'll go over that in just a minute. So here's the underlying thrombotic disease. An MI, or unstable angina, stroke, and peripheral arterial disease all have the same thing in common. They have plaque rupture, followed by adhesion of the platelets, eventually causing a clot, and you get these thrombotic events, either myocardial infarction, a stroke, or cardiovascular death. What happens when this lipid core is exposed is the beginning of the coagulation pathway. All of these intermediaries here, thrombin, ADP, 5-HTP, TXA, all those things that you learn in a physiology class, is what goes into effect when you begin to get platelet activation. When that platelets, after aggregation, you get this fibrin and fibrinogen making a model here, and you get that clot to harden, that's when you're running into acute coronary syndrome. Now, I talked about the platelets being our friends when we nick our skin, whether we're shaving or let's say someone gets stabbed. Platelets are our friends in that instance because we like a nice clot, but we don't want a clot inside our head or heart. That's a disease state. These are the little factors that can affect it. When people take Coumadin or aspirin or Plavix or Eliquis, these are the areas that are worked against. Since we're not in a physiology or a pharmacology class, we don't have to remember these today.
Woohoo! Look at that silver fly!
Okay, so here's plaque rupture. I kind of think of it as you all went to high school. You all had a point where somebody's parents went out of town, and somebody said, hey, I'm going to have a few people over, 1 or 2 people, and we're going to have some beer at my house because my parents are out of town. That's the beginning of the plaque rupture. So you invite a friend, and he invites a friend, and they invite a friend. Before you know it, this little platelet party all shows up. They adhere to the lipid core, and they begin a fibrous cap. Well, if that's all there was to it, that'd be great, but that's not the way it works, is it? You tell 2 friends, and they tell 2 friends, and before you know it, You've got all these people passed out on your lawn, okay? And that's what happens with a clot. Everybody invites their friends. Before you know it, it gets more and more. All these platelets are aggregated. The clotting cascade begins, and our friend fibrin's going to come in and put all that mesh together and anchor that clot. That's why we give, at this stage, at the very first sign of chest pain, people should be taking aspirin to try and prevent fibrin clot from going on. When we get to this point and it's in a heart attack, and we can see it on an EKG change, that's where I might throw in something called a clot busting agent, where it goes in and breaks up these fibrin clots, and I use an activator to try and do that. So, current therapy for unstable angina and non-STEMI. These are the patients who are not having an active heart attack that we can see on the EKG. We're going to give them oxygen, oxygen, nitroglycerin, beta blockers, ACE inhibitors, antiplatelet therapy, anticoagulant therapy. These are all in the acute phase. And then the maintenance therapy, we're going to put them on. These are the people that you'll pick up and take home from the hospital. They'll usually be on a beta blocker or a calcium channel blocker, sometimes both, a lipid lowering agent, and these are all maintenance therapy. We talked about this last time when we talked about EKGs, and you'll see our normal state here. Here's our normal PQRST, and as we begin to stress the heart and the clots begin to form, we'll go from normal to ischemia to injury to infarction, and we'll watch the EKG slowly change. The T waves will flip, and then we'll start to get an elevation of the ST segment. Before you know it, we get this classic fireman's hat, and that's a STEMI. We talked about this last time as well. Know your infarct regions, your anterior leads, 2, 3, and 4, supplied by the left anterior descending artery. Inferior leads, 2, 3, and AVF, supplied by the right coronary artery. And the lateral leads, V5 and V6, AVL, supplied by the left anterior descending or the circumflex. The septal region is V1 and V2, left anterior descending, and the posterior aspect of the heart is the right coronary artery. Keep in mind that we talked about reciprocal regions, which we'll talk about in a second, but we showed you this last time. If you can memorize this box as you look at an EKG, you can figure out if somebody's having an inferior MI, septal MI, anterior or lateral MI. Remember that inferior and lateral leads talk to each other. So very often we have reciprocal changes. So if we have ST elevation in our lateral leads, we're going to have flipped T waves in our inferior leads. Or if we go over here and our inferior leads are having elevation, we're going to show ischemia or flipped T waves in our lateral leads. Those are called reciprocal changes. All right, now we're going to leave MI and go on to heart failure. Normal healthy heart is on the left. You can see that it's strong. It's got good thick walls. The valves act in a one-way direction. The blood comes in, the blood goes out. In congestive heart failure, we might have valvular disease, or you can see this healthy heart is thin. This wall gets larger and larger. When I was a first-year medical student, my cadaver had a huge heart, probably 2 or 3 times the size of other people's heart, because I had a patient who had chronic congestive heart failure. A very, very thin vessel, and this, remember, this is a pump, and eventually it's a weak pump because it can't pump as strongly as a healthy heart.
body. And like all pumps, it can run into problems and eventually fail. This is called heart failure, but it doesn't actually mean that the heart stops entirely. After a lifetime of strenuous work, a failing heart is simply no longer strong enough to pump the body. The heart is an amazing organ. Each day, it beats nearly 100,000 times by our body steady flow of blood. When the heart pumps, its left and right sides contract or squeeze in unison. The left side of the heart pumps blood to the body, while the right side pumps blood to the lungs. Let's take a closer look at how the heart typically functions. The heart's main pumping chamber, the left ventricle, is located on the left side of the heart. The left ventricle pumps blood to the body, delivering nutrients and oxygen to all of our organs. After reaching the smallest blood vessel in our body, called capillary, and delivering its cargo of oxygen and nutrients, it returns to the right side of the heart. The right ventricle pumps the blood to the lungs, where it picks up more oxygen and gets rid of carbon dioxide. The blood then returns to the left side of the heart to begin this cycle all over again. Heart failure is usually a chronic progressive condition that causes the heart to weaken. So either it isn't strong enough to pump enough oxygen-rich blood to the body, or it doesn't flow with enough blood. Heart failure can affect the left, right, or both sides of the heart. Left-sided heart failure is the most common. There are two types. In systolic heart failure, the left ventricle of the heart is not contracted with enough force to push adequate blood into circulation. In diastolic heart failure, the left ventricle loses its ability to relax, so it can't fill with sufficient blood to the heart. Heart failure can also affect the right side of the heart. When this occurs, the right ventricle loses its pumping function, leading to excess fluid accumulation in the body. Right-sided failure often develops after failure has started in the left side of the heart.
Okay, so we talk about heart failure and treatment of heart failure. It's aimed at two specific aspects of the heart. We talked about the left side of the heart here as being the afterload. That's the resistance of the left ventricle must overcome to circulate blood. So when we give somebody nitroglycerin, we're dilating these vessels, and therefore we're having afterload reduction. Preload is the volume of blood that's coming into the heart. That's the end diastolic pressure. So when we give somebody a diuretic, a water pill, and we decrease the amount of blood, we're affecting preload. So those are the two aspects of treating a heart in heart failure: nitroglycerin and diuretics. And we'll give an ACE inhibitor which will decrease the afterload by dilating these vessels and will also contribute to increasing the pumping of the heart. We talked about ejection fraction earlier. It's the amount of blood pumped into the ventricle divided by the total amount of blood in the ventricle. When we get a percentage, as I said, a normal healthy heart will have 55 to 65% ejection fraction. And in heart failure, that number goes down, usually less than 40%, all the way down to, I've seen 10%. So 10% of the blood that comes into the heart leaves the heart. You can imagine that as this patient tries to exercise, tries to get up, tries to walk, tries to sit up, that if they only have 10 to 15% ejection fraction, they're not going to have a very healthy heart. They're going to tire easily. They're going to get short of breath easy. So congestive heart failure is a common clinical syndrome resulting from any structural or cardiac disorder that impairs the ability of the ventricle to fill or eject blood. It may be caused by disease of the myocardium itself, the pericardium, the endocardium, heart valves, vessels, or metabolic disorders. such as thyroid disease. High blood pressure is the primary cause of heart failure. That's why we talked about it as one of those things that we can treat early on. And by treating heart failure, we improve cardiac health. Additional treatment, you may treat the kidneys. You may try and get in and open the vessels by treating ischemic heart disease. You might have to get a CABG, which is called revascularization or a bypass surgery. We might replace a bad valve. If a valve is supposed to be one way and it's now two-way, if we increase and replace that valve, then our heart failure symptoms might go away. We're going to treat supraventricular tachycardias, particularly AFib. We'll go over that in just a minute. And then ventricular arrhythmias, which put people at risk for sudden cardiac death. Bradycardia might be treated by a pacemaker. So we've got first degree heart block, second degree heart block, and then when the heart block gets so severe that the heart is not pumping fast enough, we put in a pacemaker and we increase the rate to 60 or 65 with using a pacemaker. We might treat people for emboli. We'll put them on aspirin or Eliquis. We might have to give them blood transfusions to treat their anemia, which usually goes along with renal disease. If somebody has sleep apnea, we'll treat that. We talked about lifestyle modifications, salt restriction, fluid restriction, and avoiding obesity, because the heavier a person is, the more they have to work. Heart failure is classically seen with signs and symptoms of jugular venous distension and other causes. Left-sided heart failure, fluid backs up into the lungs and we get that pulmonary edema, or we'll get some wheezing. We'll get cyanosis. People want to sit upright. They'll start having retractions and using accessory muscles. They might have rales or crackles, shortness of breath, and left-sided heart failure can lead to right-sided heart failure. These people get the chronic ankle edema, ascites or fluid in their abdomen, anasarca, which is total body edema, and distended neck veins. A left ventricular assist device is something that you may run into from time to time, and it's out there and implanted. Usually these people are people who have severe congestive heart failure and they're waiting for a heart transplant. So while they're waiting, sometimes their heart failure gets so bad that a cardiac surgeon will go in and implant a little pump that will help the heart beat and bypass the ventricles so that it's electric, it's got batteries, and this little pump will actually help and assist the heart, specifically the left ventricle, and help the heart overcome heart failure. They look like this, and they're usually taken care of remotely, which means the patient picks up the phone, they call the assist nurse, they put it on a modem up to the assist device, and they make changes. But you may have and get called out to a patient who has one of these. Dilated cardiomyopathy is another form of congestive heart failure where the heart becomes dilated. I told you about my cadaver in medical school, had a huge heart, and the larger the heart, the weaker the muscle here, and if it's dilated, it just can't pump as well. We talked about shock, hemorrhagic shock meaning trauma, septic shock meaning infection, anaphylactic shock meaning an allergic reaction, and cardiogenic shock is also out there. So if we see somebody in shock, we have to try to determine if the shock that we have in front of us is cardiogenic. And we figure out that it's inadequate perfusion, not enough oxygen is getting to the vital organs, and people may pass out. They might be short of breath. We talked about that at the very beginning of the lecture. Treatment is usually pretty easy. The heart lacks the power to force the blood through the system, and it's usually brought on when at least 40% of the left ventricle is infarcted or affected. And it may be immediate, like immediately after a heart attack, or it may take 24 hours for the heart muscle to die off and become affected. Signs and symptoms we already talked about, and they're the typical signs and symptoms of shock. And cardiogenic shock implies that the source of the patient's shock is actually from the heart itself. It may be identical to other forms of shock. We'll have to use our head and figure out, is it from a heart attack? Is it from sepsis or something else? Causes of cardiogenic shock can be an infarct. You can have cardiac rupture, which we'll talk about in a few minutes. Valvular disease or trauma, somebody gets stabbed in the heart. Heart failure, which we've talked about just recently. Cardiac toxins, like an overdose of digoxin, for example, or cardiac tamponade, which we'll also talk about in a few minutes. Treatment, basic. Airway, breathing, circulation, oxygen as much as possible, small aliquots to increase the blood pressure, monitor the patient, diagnose what's causing it. We might have to use pressors like dopamine. A lot of our agencies carry dopamine because we might have to get that blood pressure up. And then once we figure out the diagnosis, get them into surgery or get them into the cath lab as soon as possible. All right, the last aspect to treat in the heart are dysrhythmias.
The most common form of sustained cardiac arrhythmia is called atrial fibrillation, a fast, irregular, twitching heartbeat caused by a breakdown in the heart's natural pacemaker. The condition can cause the blood flow in the heart to slow down or even to become stagnant and pooled, particularly in the left atrium. Here, the stasis facilitates the formation of a large clot with a structure and composition similar to those responsible for deep vein thrombosis and pulmonary embolism. This venous-type clot is made up mainly of red blood cells and held loosely together by a fibrin mesh. Such an unstable clot can break up or become dislodged. The entire clot, or parts of it, then travel with the bloodstream through the aorta and reach the brain. As the clot, or fragment of clot, moves along finer and finer cerebral vessels, it will eventually cause a blockage, resulting in an ischemic stroke. In patients with AF, strokes are generally more severe and often have fatal outcomes due to the size of the clots formed in the left atrium. Larger clots eventually block larger blood vessels in the brain. Both the clot formation in the heart and the subsequent stroke share the same underlying cause: inappropriately triggered blood coagulation, a major threat to the affected patient's health.
So the best way to think about atrial fibrillation as a cause of acute coronary syndrome or stroke is to think of that ventricle, and it becomes, you look at the EKG portion. Atrial fibrillation is multiple P waves, and then eventually you get a ventricular fire. When you get that P wave, multiple P waves, what's happening is the ventricle, or the atria rather, are chaotically beating, and it's churning like a washing machine. Because that washing machine is not stable, platelets can cause red blood vessels might be damaged, which starts the clotting cascade. And before you know it, a clot forms in the atria. And if it goes out of the atria into the heart, it's a heart attack. If it goes into the lungs, it's a pulmonary embolus. If it goes into the brain, it's a stroke. Or if it goes down to the legs, it's called a DVT. All right, the other dysrhythmias we're going to talk about are ventricular fibrillation. And what happens here is it's a chaotic beating of the heart, and there's no organization. So as you look at this heart here, you get PQRST here, PQRST here, PQRST here, and nothing is talking to each other. And it's described as, you can actually see this when I was also in med school, we saw this in dog lab, by giving an overdose of electrolytes, we could watch the heart go into VFib, and it looked like a bag of worms. So if you can imagine a bag of worms, and those worms are crawling all over the place, and there's no organized beating of the heart. That's why the EKG looks chaotic, and the treatment is easy. Defibrillate. We use defibrillation, boom, reset the heart, and all of these now will talk to each other. Ventricular tachycardia is different. That's where the bottom of the heart takes off in a fast rate. You can see it's QRS, QRS, QRS. That's what's going on in the EKG. And you can have ventricular tachycardia that's stable, meaning they're not having chest pain, they're not having shortness of breath, and sometimes we'll try amiodarone on these people and try and slow them down and reorganize this ventricular tachycardia into a rhythm that looks good and convert them to a sinus rhythm. Or if it becomes unstable, chest pain, shortness of breath, or they begin to feel as if they're going to pass out or their blood pressure goes down, we defibrillate again, reset all these electrically. We'll still give our amiodarone, and then we'll try and bring them out of that electrically. Of course, asystole is bad. That means that the heart is silent. It's not moving at all. You've got no organized rhythm at all. So that takes CPR until we can get them into a shockable rhythm, and then we give them epinephrine to stimulate the heart to beat more. Pulseless electrical activity is when the heart is actually giving you a formed complex, a PQRST, but there's no beating of the heart. There's no response. There's no muscle. That's our 5 T's and our 5 H's that we talk about in our advanced cardiac life support. We'll talk about that another day. There's no defibrillation in PEA. Treatment is only epinephrine. Signs and symptoms of cardiac compromise. I throw this in there again because they're going to all be possible signs and symptoms that we've already talked about. Lastly is cardiac tamponade. Tamponade can happen by a rupture of a vessel or an injury to the muscle. Maybe somebody hits the steering wheel and they cause a small tear, or somebody gets stabbed in the heart and the blood begins to bleed, and the pericardium, which is the sac in which the heart sits, gets overwhelmed with blood. We can see that in the next illustration. All right. The treatment, of course, for cardiac tamponade is to place a needle in the pericardium. That's usually directed from the outside. You're going to take a long needle with a clip on it so you can watch the EKG, and then you're going to put it into the pericardium and then withdraw the fluid that accumulated. Pericarditis is inflammation of the outside of the heart. The way to diagnose pericarditis is it looks like a STEMI, but it looks like a STEMI all over the heart. So you've got inferior, anterior, septal, and lateral leads all inflamed at once, and it looks like the patient's having a heart attack, but on every aspect of the heart. So usually it's caused after a virus. The treatment is pretty standard. We'll do an echocardiogram and get them on some anti-inflammatory, and they usually don't need to see a cardiologist. All right, that's it. That's our review of all things considered for the heart. Questions?
Okay, folks, now's your chance. Do you have any questions for Dr. Eschelbach? And even if you don't, at least unkey or type in that you're still here and that I can give you credit. Leanne, I did not see when you came in, and I don't know exactly who you are. And all I see is Leanneg. I don't have a name. Who is this? And I lost somebody that was here before. Tad Roper. Okay, let's see. No questions. Roper says, how is ejection fraction measured?
All right, that's a good question. We can take an ultrasound, and this is a great lesson in learning from students. I have a emergency medicine student right now who loves to do ultrasound. And the other day he showed me the heart. He said this person's in heart failure. And then he took the ultrasound and put the heart in M mode. And by measuring across the diameter of the heart, he could tell that only 35% of what was coming into the heart was going out. So it's usually done by an echocardiogram. There is a way to measure it by, and this is an old-fashioned method where you put dye into the heart and you measure how much you put in and how much comes out. But that's an older method, and now most of the time ejection fraction is measured by an echocardiogram or an ultrasound. So we have Leanne Grade. Sorry, all right. Maybe about halfway through. Okay. Any other questions?
Oh, it looks
Thank
like
you.
we're
You're
good
welcome.
today. Thank you, sir. We appreciate your time. Folks, I will be posting this in the MD Roundtable in a few days, and also we have another MD Roundtable same time on Wednesday night with Dr. Frame. So if you need more roundtables, then we'll be doing another one this week. All right, I'm closing this up. Thank you, sir, for helping us out tonight.
All right. Have a great one. Good night, everybody.
Good night.